Picture this. You're 74 years old. You feel good. Not just okay, genuinely good. You're sleeping through the night, your energy is holding, you're doing things you love. Maybe it's gardening, maybe it's fishing, maybe it's watching your grandkids run circles around the yard. Life isn't perfect, but it's yours, and you're living it. You go in for your annual physical. Routine. Unremarkable. You've done it 100 times. Your doctor glances at your chart, maybe a little too quickly, and says those 7 words that sound so reasonable in the moment. Let's just run a few tests to be safe. You nod. Of course, better safe than sorry. 6 weeks later, you're sitting in a surgeon's office, not because you felt sick, not because anything was wrong with you when you walked in, but because those just-to-be-safe tests found something, and that something set off a chain of events that your 74-year-old body was never equipped to handle. The life you were quietly enjoying? It looks very different now. That exact story plays out thousands of times every year in this country. And the data behind it is something every person over 60 deserves to understand, before their next appointment, not after. My name is Dr. Franklin. This channel exists for one reason: to help adults over 60 understand what the research actually says about their health, in plain language, without the 15-minute time crunch your doctor is working under. What I'm about to share isn't drawn from a single textbook or one controversial opinion. It comes from years of studying the medical literature carefully and paying close attention to what the evidence shows when the system runs on autopilot. And here is what the evidence shows. After the age of 70, some of the most common routine medical tests can cause more harm than good. Not because medicine is broken, not because your doctors are careless, but because the risk-to-benefit math changes dramatically as we age. And nobody in that exam room is doing that math out loud with you. Today, I'm walking you through 5 specific medical checkups I would personally reconsider after 70. I'll explain exactly why the math shifts, I'll share what I've seen happen to real people, and at the end, I'll give you 5 precise questions that will completely transform the dynamic in your next doctor's appointment. Stay with me through all 5. Number 3 surprises nearly everyone the first time they hear it. And number 5 is the one most people have never even considered until it's too late. Before we get into the 5, I need to give you one concept. Without it, nothing I'm about to share will fully land. The longevity lens. When you're 50, screening medicine works beautifully. You find a problem early, you treat it aggressively, and you potentially buy yourself 30 more healthy years. The investment makes complete sense. The math is clean and clear. But something fundamental shifts after 70. 3 things specifically. First, many conditions found through routine screening in older adults will never actually harm you. They grow slowly. They cause no symptoms. In many cases, you will simply outlive them. But medicine doesn't have a leave it alone button. It has a treatment button. And once something shows up on a report, that button tends to get pressed. Second, your body's tolerance for intervention drops with age. The surgery a 55-year-old bounces back from in 2 weeks can mean months of recovery, serious complications, loss of independence, or worse, in a 78-year-old. Third, and most insidiously, there is something called the cascade effect. One test finds a small abnormality. That triggers a follow-up scan. The scan leads to a biopsy. The biopsy recommends a procedure. The procedure causes a complication. And suddenly, a person who walked in feeling perfectly fine is navigating a medical nightmare, one that began with a test they didn't need. That is the longevity lens. Keep it with you as we go. Checkup. Number 1. Routine colonoscopy. After age 75. Dorothy was 77 years old. A retired librarian from rural Tennessee, sharp, warm, the kind of woman who still remembered every patron's name from the library she'd run for 30 years. She'd had 2 colonoscopies in her 50s and 60s, both completely clean. No polyps, no family history of colon cancer, no symptoms, not a single warning sign. But her new primary care doctor looked at her chart and said she was due for another one. Dorothy had her doubts. She did her research. But she didn't want to seem difficult, so she went ahead. The night before the procedure, she drank the prep solution, the liquid designed to clear your bowels entirely. By morning, she was confused, dizzy, and could barely stand. Her daughter found her and rushed her to the emergency room before she ever made it to the procedure room. Dorothy was severely dehydrated. Her electrolytes were so dangerously low that her heart was at risk. She spent 4 days in the hospital. She never had the colonoscopy. And the quiet tragedy of it? She didn't need one. The United States Preventive Services Task Force, the gold standard body that sets screening guidelines in this country, officially recommends against routine colonoscopy screening for average-risk adults over age 75. The evidence is unambiguous. After 75, if you have no symptoms, no family history, and clean previous scopes, the risks begin to outweigh the rewards. Those risks are real. Bowel perforation, a literal tear in your colon, occurs in roughly 1 in every 500 colonoscopies. In a younger adult, that's a manageable complication. In a 77-year-old, it can mean emergency surgery, a colostomy bag, extended hospitalization, and a recovery that permanently changes your quality of life. Meanwhile, the colon cancers most likely to be found in asymptomatic older adults tend to grow so slowly they would never cause problems within a person's remaining lifetime. What to do instead? Ask your doctor about non-invasive stool-based tests like the Cologuard or the annual FIT test. These can catch genuine warning signs without the procedural risks. And if you do have symptoms, blood in your stool, unexplained changes in bowel habits, that changes everything. See your doctor right away. Checkup. Number 2. Aggressive PSA and mammography screening for low-risk, asymptomatic patients. Let me be precise here, because this topic demands nuance. I am not saying never screen for cancer. Cancer screening has saved millions of lives, and it can absolutely save yours. What I'm saying is this. After 75, aggressive cancer screening in average risk, symptom-free individuals has a serious overdiagnosis problem. And overdiagnosis leads directly to overtreatment. Treatment that carries real costs with no real benefit. Here's what overdiagnosis means in plain language. Today's imaging technology is so sensitive it can detect cancers that are, biologically speaking, barely awake. Tiny, slow-growing tumors that, left alone, would never spread, never cause a symptom, and never shorten your life. You would die with them, not from them. But the moment a radiologist writes the word malignancy in a report, the clinical machine switches on. Biopsies, specialist referrals, treatment planning. All of it moves forward, regardless of whether the cancer actually poses any threat to that specific person. Richard was 79 years old, a retired mechanic from Georgia, still sharp, still independent, still getting out on the water to fish on weekends. A routine PSA test came back slightly elevated. A biopsy confirmed a low-grade, slow-moving prostate cancer. His urologist recommended radiation therapy. Richard trusted the recommendation. He went through treatment. Within a year, he was dealing with chronic fatigue and urinary problems. His quality of life had dropped dramatically. Stories like his fill the medical literature, men who later understood that their cancer was the kind you live alongside, not die from. Men who, with full information, might have chosen differently. Studies published in the New England Journal of Medicine found that a substantial portion of cancers detected through mammography in women over 70 were clinically insignificant, meaning treatment offered no survival benefit, only side effects. What to do instead? Have an honest, specific conversation with your doctor about your individual risk profile. If you have a family history, genetic markers, or symptoms, screen. If you're average risk and symptom-free, ask this question directly. If we find something, what are the realistic treatment options at my age, and what would we actually recommend? That question alone changes the room. Checkup. 3. Routine cardiac stress testing without symptoms. This one surprises people because it sounds so responsible. You're 72. Your doctor says, let's just make sure your heart is doing okay. You get on a treadmill, or they give you a medication that temporarily stresses your heart while they monitor the response. Sounds careful. Sounds like good medicine. Here's the problem. Cardiac stress tests in people without symptoms have false positive rates that can reach 40% or higher in certain populations. Nearly half the time, the test flags an abnormality when your heart is completely fine. But medicine can't simply shrug at an abnormal finding. That false alarm launches the next phase, a cardiac catheterization, threading a thin tube through your blood vessels directly into your heart. This is a serious procedure. Risks include bleeding, vessel damage, irregular heart rhythms, and in rare cases, it can trigger the very heart attack or stroke you were trying to prevent. And if the catheterization finds a partial blockage, extremely common in adults over 70 who have zero symptoms, you may end up with a cardiac stent. Here's the part that stops people cold. Multiple landmark clinical trials, including the widely cited ischemia trial, found that stenting patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle management alone. Let that sink in. The stent didn't help more than the medication, but it carried real procedural risks, and then a lifetime of blood thinners with their own bleeding complications. So you started out feeling fine, had a routine test, got a false alarm, went through catheterization, received a stent, now take blood thinners daily with ongoing monitoring, and you are statistically no better off than someone who simply managed it with medication and a 30-minute daily walk. What to do instead? If you have no chest pain, no unexplained shortness of breath, no dizziness during exertion, routine stress testing is searching for problems in a population where intervention doesn't consistently help. Focus the conversation on optimizing your modifiable risk factors: blood pressure, cholesterol, blood sugar, activity, sleep. That's where the real gains live. Checkup. 4. Routine bone density DEXA screening, followed by automatic medication. Osteoporosis is real. Falls are devastating in older adults. So let me be careful here. I'm not questioning the reality of bone loss with age. I'm questioning the automatic pipeline that often follows a DEXA scan result in patients over 75. Here's how it typically goes. A DEXA scan shows low bone density. Your doctor prescribes a bisphosphonate, medications like alendronate or risdronate. You take it for years, assuming you're protected. What often goes unmentioned, long-term bisphosphonate use has been associated with a rare but serious condition called atypical femoral fractures, spontaneous stress fractures in the thigh bone, the very bone you were trying to protect. These fractures can be severe and require surgery. The medications are also linked to osteonecrosis of the jaw, painful, difficult to treat bone deterioration that can significantly impact your quality of life. Meanwhile, the single most effective intervention for preventing fractures in older adults isn't a medication at all. It's fall prevention. Balance training, Tai Chi specifically, has been shown in studies to reduce fall risk by nearly 50%. Removing tripping hazards from the home, installing grab bars, reviewing medications for ones that cause dizziness, getting regular vision checks, ensuring adequate protein and vitamin D. These interventions reduce fracture risk more meaningfully than any pill, with zero side effects. What to ask? Before we talk about medication, can we go through my specific fall risk factors together? And what's the actual fracture risk reduction from this medication compared to a structured fall prevention program? Those two questions can completely redirect the conversation. Checkup. 5. Asymptomatic carotid artery ultrasound screening. This is the one almost nobody is talking about. And based on what the research shows, it may be the most quietly consequential of all 5. A carotid artery ultrasound scans the large blood vessels in your neck that carry blood to your brain. The logic seems sound. Find a significant blockage early, clean it out surgically, reduce your stroke risk. The reality is far more complicated, and for asymptomatic patients, far more dangerous than it sounds. The surgical procedure used to treat a carotid blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after the surgery. In older adults with additional health conditions, that risk is higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults who have no symptoms, no mini-strokes, no sudden vision loss, no neurological episodes. Their analysis found that in asymptomatic individuals, the risk of surgical harm outweighs the benefit. Here's why. Many people over 70 have some degree of narrowing in their carotid arteries. That narrowing has often been stable and silent for years, causing no problems whatsoever. When you screen for it routinely, you find it, and then a well-meaning surgeon recommends fixing it. But the surgery to remove a blockage that was never causing symptoms can, and sometimes does, dislodge a tiny piece of plaque that travels directly to the brain. I won't walk through a single case study here, because the documented outcomes in the medical literature are too significant to reduce to one story. People have walked into routine screening appointments and left on a completely different life trajectory, not because of the blockage that was found, but because of the intervention that followed. What to do instead? If you have no neurological symptoms, no sudden vision changes, no facial drooping, no arm weakness, no unexplained severe headache, routine carotid ultrasound is not recommended. The far better investment is controlling the actual modifiable stroke risk factors: blood pressure, the single biggest driver, blood sugar, atrial fibrillation management, and staying physically active. If you do experience any neurological symptoms, even brief ones that resolved on their own, get evaluated immediately. That changes the entire picture. The 5 questions protocol. I promised you something practical. Here it is. Every time your doctor recommends a screening test, especially if you're over 70 and feeling well, bring these 5 questions. Write them down. Put them in your phone. They will change the dynamic in every appointment. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to launch unnecessary follow-up procedures even when nothing is actually wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? This forces the conversation toward real outcomes, not just findings. Question 3. What is the procedural risk of any treatment we'd likely pursue? Most people never think to ask this up front. Every procedure carries risk. You deserve to know it before you agree to anything. Question 4. What happens if we monitor this instead of treating it right away? Watchful waiting with regular monitoring is a legitimate and often superior option for many conditions found in older adults. Question 5. What is the most effective non-invasive intervention for this condition? Because very often, as we've seen today with bone health, heart health, and stroke prevention, lifestyle changes and medication outperform procedural intervention with a fraction of the risk. Any physician who is genuinely focused on your well-being will welcome these questions. They'll respect you more for asking them. And if your doctor dismisses these questions or makes you feel difficult for raising them, that's important information about whether that doctor is the right fit for you. A final word. There is a difference between medicine that finds things and medicine that helps you live well. After 70, the goal of your healthcare shouldn't be to generate findings. It should be to protect your quality of life, your independence, your energy, your ability to do what matters to you. The best physicians understand that doing less sometimes takes more wisdom than doing more. That recommending watchful waiting requires more courage than ordering another scan. You have the right to know what a test is looking for. You have the right to know what happens if something is found. You have the right to ask whether a finding would actually be treated, and whether that treatment would genuinely improve your life. Medicine has given us extraordinary tools. But tools are only helpful when used in the right context, at the right time, for the right person. You are that person. And you deserve healthcare that is built around your goals, your values, and your body, not around a checklist. If this gave you a new way to think about your health after 70, subscribe. I publish videos like this every week, practical, evidence-based, and honest. And leave a comment below. Have you ever had a routine test lead somewhere you didn't expect? Your story might be exactly what someone else needs to hear before their next appointment. Take care of yourselves. I'll see you in the next one.